So the last part of Learning Plan 8, High Risk Perinatal, is going to focus on intrapartum complications. When we say intrapartum, we're talking about labor and delivery. Nurses have a challenge here because we need to identify and manage these complications promptly. We don't have time to wait. And we need to provide care to the patient while supporting that entire family who is panicked about what's happening. Types of intrapartum complications that we're going to, this is the big list, and we're going to focus on some of these. First of all, any kind of dysfunctional labor. We think about the 4 Ps, the passenger, the passageway, the powers, and the psyche. So any kind of problem in any of those areas. Shoulder dystocia, which is difficult delivery of the shoulders. Fetal size and presentation position issues, pelvic size issues, fetal anomalies. We have the abnormal labor duration, prolonged labor or precipitous labor, premature rupture of the membranes, preterm birth, fetal distress, uterine rupture, prolapsed umbilical cord, amniotic fluid embolism, and uterine inversion. We're not going to discuss all of them, but this is the big list of all the possible types of complications you could see during labor and delivery. First of all, fetal size. So if we have that macrosomic baby that we were talking about earlier, a very large infant who weighs greater than 4,000 grams, you can have problems with the delivery. The size is going to be relative to the size of the pelvis, but the head and the shoulders may not adapt to the pelvis, and the distension of the uterus is going to reduce the strength of the contractions. Then you could have shoulder dystocia, difficulty of delivering those shoulders with a very large baby. So delayed or difficult birth of the shoulders is the definition, and those shoulders become impacted above the maternal symphysis pubis. It's unpredictable, and shoulder dystocia could occur with any weight, with any baby size, but it requires urgent intervention because the umbilical cord is being compressed, but the chest compression within the vagina prevents the respiration. So you need to act quickly. And several methods may be used. One is McRoberts maneuver, one is suprapubic pressure. So the nurse gets up on a stool, providing suprapubic pressure, not pushing on the fundus, but pushing on the suprapubic area to help those shoulders deliver underneath the symphysis pubis. With McRoberts maneuver, you have mom's both of her legs flexed up toward her abdomen and then abducted outward to try to widen that pelvic area. So she flexes her thighs sharply against her abdomen, and that straightens the pelvic curve. And sometimes you can have them do this in a squat, and that will add gravity to their pushing efforts. With the suprapubic pressure, as I mentioned, an assistant is going to push that fetal anterior shoulder downward to displace it from the maternal symphysis pubis. And as I mentioned, we're not providing fundal pressure because this will just push the anterior shoulder more firmly against the mom's symphysis. Now, premature rupture of the membranes, by definition, it's rupture of the amniotic sac prior to the start of true labor, regardless of what the gestation is. And so she could be full term, but labor hasn't really started, but then her membranes rupture and she has no further symptoms of labor. Probably the most common reason is infection, but you also could have the amniotic sac that has a weakened area, or a previous preterm birth, fetal abnormalities, or any malpresentation, an incompetent cervix or one that has a short cervix, overdistension of the uterus, so twins, triplets, polyhydramnios, etc., maternal hormone changes, recent sexual intercourse. We know that semen has prostaglandin. Prostaglandin does soften the cervix, and that's a great thing for when you want to try to induce labor, but if it causes rupture of membranes and no labor, you have PROM. Maternal stress and maternal nutritional deficiencies. Some of the complications here are that both mom and baby are now at risk for infection, both during labor as well as postpartum. Anytime the membranes are ruptured, you now have an increased risk of an ascending infection. And the research has shown that when the membranes are ruptured 18 hours and longer, the risk of infection to the fetus goes way high. So we say that we want to deliver that baby within 24 hours of the membranes being ruptured. Chorioamnionitis, that might have been the cause of the PROM that caused it in the first place. So you might see maternal fever, uterine tenderness. If the membranes are ruptured well before term, way long before, they may form a seal, and that stops that leaking fluid and allows for that amniotic fluid cushion to become reestablished. However, if they continue to leak, the umbilical cord becomes compressed and you have reduced lung volume and you can have other fetal deformities. So therapeutic management is going to depend on the gestational age of that fetus and whether there's any evidence of infection. If she's 34 to 36 weeks, they can induce labor or do a C-section. If she's earlier than 34 weeks, the decision is much more complex. So preterm birth. If possible, we try to stop the delivery, stopping it before there's the point of no return, which once you get past 3 centimeters, it's a lot harder to stop it. So we can try to treat infections. If those are present, that might stop that irritability of that uterus. Restrict her activity, so bed rest, and hydrate her. Just hydrating her tends to calm the uterus down. Tocolytics are medications that are given to try to stop the uterine contractions. They will delay the delivery, but they don't actually prevent it. So they're usually prescribed when they're less than 34 weeks. And they may or may not be effective, but one of the most effective drugs is magnesium sulfate. Remember, magnesium acts like a sedative, so it's a smooth muscle relaxant. There are other meds that can be given. Tributaline is one. It's a beta adrenergic drug. It stops contractions, but the side effects are tachycardia. It may or may not have good results. There are prostaglandin inhibitors like indomethacin, which might be used to inhibit uterine contractions. And then we also have calcium channel blockers. Nifedipine is one. It will block the contractions because the need is there for smooth muscle. In order for a smooth muscle to contract, it needs calcium. Probably the best medication, most effective for stopping preterm delivery is magnesium sulfate. So now we're going to talk about these intrapartum emergencies: fetal distress, uterine rupture, prolapsed umbilical cord, amniotic fluid embolism, and uterine inversion. When we think about fetal distress, we know the fetus is not tolerating the labor process. So anytime the oxygen supply is insufficient to meet the physiologic needs of the fetus, you will see non-reassuring fetal signs. And this status of the baby may be transient, that comes and goes, or it could be chronic, and it may be prompted by a variety of factors. The most common causes are cord compression and uteroplacental insufficiency. But if you see hypoxia in the fetus and it persists, and now they have metabolic acidosis, this situation could always cause permanent damage to that fetus or be life-threatening to the fetus. Now, common signs, the initial signs are going to be any variations from the normal heart rate pattern and decreased fetal movement. So when we look at evaluating the heart rate patterns, we need to look at the fetal monitor tracing and establish what's the baseline fetal heart rate, are there any variabilities in the baseline rate, and do we see any periodic changes in the rate? So first of all, looking at the baseline fetal heart rate, we have to analyze a range of fetal heartbeats over a 10-minute tracing. Look between contractions. Where does that rate tend to be? The rate will fluctuate with fetal movement and sleep. Our baseline change, we first establish what the fetal heart rate is, and in order for you to say the baseline rate has changed, you need to have this new rate occurring over a 10-minute period. Fetal bradycardia could be a vagal response due to head compression. You'll see the fetal heart rate less than 120 beats over 10 minutes. And then fetal tachycardia, you'll see the fetal heart rate at greater than 160 beats over 10 minutes. And this could be due to hypoxia, maternal fever, drugs that are being given, fetal arrhythmia, maternal anemia, and hyperthyroidism in mom. The next thing we look for is variability. Remember, those are those irregular or jittery movements of the fetal heart rate, and it's variation in the heart rate over time. Variability is good. Fetal heart rate variability is considered the most reliable sign of that fetal well-being in labor. So you want to see lots of variability, lots of those jitters. If you have no variability, it might be because that fetus is responding to narcotics or barbiturates, or the baby has fetal hypoxia, fetal acidosis, or maybe a very immature fetus that has a decreased nervous system. Next, we look for periodic changes. Those are those accelerations and decelerations. They will occur in response to contractions and fetal movement. Accelerations are a temporary increase in the fetal heart rate due to fetal movement or compression of that umbilical vein during the contraction. And then we have three types of decelerations. You'll remember that we did start talking about these in second semester, and we're going to review those here. Early decelerations, variable decelerations, and late decelerations. So your early decelerations begin and end with the contraction. So they start to drop early in the contraction pattern and come back to baseline early. So they begin and end with the contraction. The causes are pressure on the fetal head compression. This is a benign, harmless, normal situation. This occurs usually late in labor because the head is very low. Remember I said if you see a whole bunch of early decelerations, it is time to go check her because she may be complete and pushing, and you have all that pressure on the fetal head. Variable decels occur at unpredictable times. They're variable in their timing and variable in their shape. Remember here the cause is cord compression, and the interventions here would be to change her position and give her oxygen. So with variable decels, you've got cord compression. Probably that fetus is laying on its own cord, so no matter what position she's in, you're going to change it. If she's on her left side, don't keep her there, even though we have best perfusion to the fetus and the placenta on her left side, because in this side, it's causing something to put pressure on the cord. So change her position and then give her oxygen. And you might be saying, I'm going to do them both at the same time. So if it were a select all and apply question, that's fine. But if it's not, which one will you do first? Change her position. Late decelerations, the most ominous of all decelerations. These do not start decelerating until after the onset of the contraction, maybe 30 to 40 seconds after the contraction has started, and they continue beyond the end of the contraction. They're late starting and they're late coming back to baseline, and the cause is uteroplacental insufficiency. You've got decreased blood flow to that placenta. It's a very ominous sign, and the interventions here would be change her to her left side. That's our number one thing. These are not in any specific order, but that always reduces the aortic compression and it brings more blood to the uterus. So turn her on her left side, then give her oxygen, and then prepare for delivery if she's ready to deliver. Otherwise, we're going to probably do a C-section. So select all that apply. I would select all those in addition to maybe calling the physician. But if it was, what am I going to do first? If there's only one thing I could do, it would be turn her to her left side. Now, these decelerations, I have something posted out on the website that is called Veal Chop, and it has each one of the contractions or the decelerations, what they look like usually, and what the cause is. Now, the variable decels, I forgot to say, usually take the shape of a V, a W, or a U. They're very abrupt in their drop, very abrupt in their coming back up. They're not a nice gradual contraction in bell-shaped curve at all. Gradual deceleration. That would be the opposite of a bell-shaped curve. The next one we're going to talk about is prolapsed umbilical cord, and this is where the umbilical cord is going to slip down in front of the fetal presenting part. It's always more likely to occur when the fit is poor between the fetal presenting part and the maternal pelvis. The conditions where it's more likely to occur is whenever the fetus remains high in station. Remember, station is how far down that fetal head is in the pelvis. A smaller fetus, it's more likely a breech presentation or a transverse lie, or anytime you have a large amount of fluid, the hydramnios, because it's putting more pressure to push that cord out. So if I need to figure out whether this mom can walk and ambulate or not, all these things are taken into consideration, but the most important factor is where is that fetal station? Where is that presenting part? Because if I have any space between it and the outside, then I have a risk for that cord to prolapse. So as long as that fetal presenting part, hopefully the head, is at the 0 station, then nothing can get down in front of that fetal head, including the cord. And so we do have a case study that we'll be doing in class on that. Management, the priority here is to relieve pressure on that cord to restore the blood flow. So we need to act fast. If you have your hands in the vagina, you should lift the presenting part off the cord. If you don't have your hands in there, you better get them in. Always position her hips higher than her head. So that means Trendelenburg, to shift the fetal presenting part toward her diaphragm, but never, ever, ever try to push the cord in. Leave the cord alone. You don't want it to vasospasm or have any trauma that could reduce further blood flow to that fetus. So you're attempting to lift the presenting part or change her position. Other actions, you can give her oxygen. A tocolytic may be given to stop contractions. And if that cord is protruding out of the body, rapid and warm saline. The promptest delivery possible. So this is an emergency, and that's usually going to be an emergency C-section. Remember, we have 2 true obstetric emergencies. One is our abruptio placenta, and the other one is a prolapsed cord, and here we are with that. Okay, now there were some other intrapartum complications and emergencies. We had the amniotic fluid embolism, the uterine inversion, the uterine rupture. I'm not including any dialogue on those here because they're very rare situations. I won't be testing you on any of that, but we can have a little discussion in class about it as I have some experience with some of those. And you may or may not see that on your NCLEX. So this is going to end the class recordings for Learning Plan 8, High Risk Perinatal.